The COVID-19 pandemic has brought healthcare back into focus. We've all begun to realize that we need to be investing more into our healthcare, in infrastructure, human resources, R&D, as well as in putting the right kind of systems in place. I passed my MBBS in 2001, so I've been a doctor for nearly 2 decades now. And I've spent almost half of that period working in India and the rest for the National Health Services UK. What I'm going to share with you is partly based on my own observations and reflections, but also on more objective learning and research. When I was a kid, I used to watch a lot of old Hindi movies on Doordarshan. And the typical doctor in those movies would be a well-dressed middle-aged man who would emerge out of the patient's room with a black suitcase and declare to the family, चिंता की कोई बात नहीं, मैंने उन्हें इंजेक्शन लगा दिया है, सुबह तक उन्हें होश आ जाएगा. Meaning, there's nothing to worry about, I've given him an injection and he will be fine by morning. I was quite fascinated by that character. I sometimes wonder whether it had a subconscious impact on my choice of profession. But when I finally did become a doctor, much to my disappointment, I realized that that magical injection did not exist. Healthcare systems are far more complex today. For example, think of an operation theatre or an intensive care unit. Think of all the high-tech gadgets, people with varying skill sets, the potentially toxic drugs being used, support from the diagnostic labs, IT support, communication which could be verbal, written, digital, all sorts. And at the center of it all, a sick patient. Things could go wrong at any level. Errors could have a cascading effect with disastrous consequences. For example, imagine that a tired nurse or a doctor who's been up all night puts the wrong label on a cross-match sample. Now, for those of you who are not from a medical background, cross-matching is the process of testing whether the blood meant for transfusion is compatible with the patient's own blood. So this could lead to a fatal transfusion reaction. But are we imagining things, creating unnecessary paranoia, or is this real? Well, I have seen things going wrong on so many occasions, and from both ends, as a doctor, as well as in the case of my own relatives when they've been unwell and admitted. But going beyond personal experiences, there were 2 studies in 1997 in America, the Harvard Medical Practice Study and the Utah and Colorado Medical Practice Study, that looked into deaths occurring due to medical errors. And when they extrapolated their findings for the entire country, they estimated the average number of deaths per year due to medical errors to be 44,000 and 98,000 respectively. Now, even if we take the more conservative of the 2 estimates to be true, that's equivalent of a jumbo jet crashing every single day. Now, it doesn't grab headlines, it doesn't have the same kind of impact on people's minds because these deaths are scattered all over the country. Initially, these findings were met with a lot of skepticism, but subsequently several studies have thrown up similar figures. The problem was officially recognized a few years later when the Institute of Medicine came up with its report titled "To Err is Human, Building a Safer Health System." Since then, patient safety has come to be recognized as a major challenge globally. WHO came with its patient safety program in 2004. And over the last few years, we have seen growing awareness even in India. But we have just quite begun our journey towards a safer healthcare. Building a safety culture in healthcare organizations is paramount. Now, what do I mean by that? Suppose I make a mistake. or my colleague makes a mistake and I happen to find it out. Now, if there is a risk of being penalized or reprimanded, what am I likely to do? I'll probably try to cover it up if it's my own mistake, or just look the other way if it's my colleagues. But then, as a team, as an organization, and as medical fraternity, will we ever learn the right lessons? Patients after patients will continue to come to harm as we will continue to make the same mistakes over and over again. So we need to break this silence, but not by pointing fingers. It's important to realize that errors happen not because of bad people in healthcare, but because of good people in bad systems. So if we want to fix the system, we have to create an environment of openness, where people don't feel threatened. They find it easy to admit their own mistakes and to report others. Healthcare organizations must lead and support their staff in creating a culture of patient safety. There are two aspects of patient safety. Risk assessment is a proactive process where you foresee a risk before an error actually takes place. So you see a loophole and plug it before anything untoward happens. So for example, you could design a toilet in a hospital in such a way that elderly and frail people don't fall down and break their bones. But there's also a reactive component of patient safety. When something goes wrong, we need to take steps to mitigate its effects and to prevent its recurrence. And this is precisely what we mean by learning from mistakes. So how do we institutionalize this? The answer is incident reporting. Healthcare organizations must encourage written reporting of all adverse events and near-miss events when something went wrong but nobody actually came to any harm. Incidents must be reported and investigated. I will give you an example from my own experience where we not only reported an incident but also tried to implement a solution. So on our wards, we have these drug charts where the doctor prescribes the medicine and the nurses sign against them when they administer them. So we had this patient with an irregular heart rhythm and we prescribed her a blood thinning medicine called warfarin to cut down her chances of getting a stroke. Now, warfarin is a double-edged sword, meaning that if we thin the blood down too much, there is a risk of bleeding. So we need to monitor its effect on the body by doing a blood test called INR. So in the case of this patient, when the INR went above 3, because we like to keep the value usually between 2 and 3. So when it went above 3, we reduced the dose. But in spite of successive dose reductions, her INR kept going up. So we withheld the medicine, but to our surprise, it still kept going up and reached quite dangerous levels. So then we decided, okay, we're done with it. We're not going to give her any more warfarin. And we reversed the INR with vitamin K, which is an antidote to warfarin. But we knew something was not right here because what had happened defied any logic. So we decided to look beyond the obvious. And after a thorough investigation, we found out that this lady had continued to take warfarin in the original dose. We needed to address this problem. Communication errors are actually one of the commonest sources of medical errors. So after a discussion with the nursing team, we decided that we were going to paste a notice by the side of each bed saying that the patients should not take any medicines on their own while they are in the hospital and that these would be administered by the nurses under their direct supervision. Incident reporting is a standard practice in most countries or in many countries of the world. When I've spoken to my colleagues and friends in India, they've all agreed in principle. But some of them have expressed concerns about creating a written record of something that could be used against them legally. I think this is a genuine concern. But I think it's still possible for healthcare organizations to work around this problem. So, for example, the incident reporting forms could be made anonymous. Furthermore, once an incident has been investigated and a report prepared, which should certainly not reveal any identities, the original incident forms could be destroyed permanently as an organizational policy. So, to summarize, patient safety needs to be embedded in the culture of healthcare organizations. It should be incorporated into the training of doctors and nurses from a very early stage, and hospitals must have a separate cell to look into patient safety issues. They must create an environment of openness. Incidents must be reported and investigated. Lessons should be learned and shared. Now, so far, I've only been talking about what organizations need to do. But in the long run, we need to look beyond organizational boundaries and forge a partnership with the public at large. We need to convey to them that creating an environment of openness is a prerequisite for safe delivery of healthcare. If doctors or other healthcare professionals are afraid of being sued or worse still, physically assaulted, they will never admit their mistakes. So rather than harassing healthcare workers, it's important to put pressure on healthcare organizations so that they put systems in place. I'm really optimistic that a time will come when doctors and nurses will find the courage that if something goes wrong, they should be able to go and tell the patient as well as their relatives about what has happened, what steps have been taken to minimize harm, and reassure them that lessons will be learned and implemented. Not all errors are preventable, but certainly with vigilance and constant efforts, we can minimize their occurrences. So let us join hands today to create a safer healthcare tomorrow. We shall overcome one day.